So, think about the last time you went to a doctor. You have almost certainly had, or at least heard of, a condition ending in anaphyllitis. I mean, bronchitis, arthritis, dermatitis, you name it.
Oh, absolutely. It's everywhere.
Right. It is the ultimate medical shortcut. You just learn a Greek root for a body part like hepato for liver, slap this itis on the end, and boom, you have a diagnosis, hepatitis.
Yeah, it feels incredibly clean and efficient, you know,
Mhm.
but it's actually super deceptive.
Which is exactly our mission for this deep dive. We are jumping into this provided medical text to explore how this one tiny ancient suffix created just a massive flood of terms in our vocabulary.
A flood of terms that honestly frequently mask what is actually happening in your body.
Exactly. We want to track how our understanding of this word ending shifted from, well, ancient clinical guesswork all the way to modern high-tech sports science.
Because the core definition here is actually really simple. Pediatritis just means inflammation of. That's it.
But the text makes a huge point about what that actually implies, right?
Right. The main thesis is that any itis describes a tissue-level process. It is the inflammation itself. It is not a root cause.
So it tells you exactly where the fire is burning.
Yes, exactly. But it tells you absolutely nothing about who or what started the fire.
Which is wild when you think about how we use it. So before we can understand the specific diseases, we really have to understand what inflammation actually is.
And how humanity's definition of it completely changed over time.
Yeah, let's go back to the ancient Greek roots. Physicians used the suffix to modify the feminine noun nosos, which just meant disease.
Right, so diagnosing arthritis literally just meant the disease of the joint. It was entirely a geographic label.
Like, hey, the problem is over there.
Pretty much.
Yeah.
And it stayed that way, just a macroscopic observation, for centuries.
Until the Romans got involved.
Yeah, around 30 CE, you have the Roman encyclopedist Celsus.
Oh.
Now, he didn't invent the itis terminology because he was writing in Latin, but he categorized exactly what doctors were seeing with their naked eyes.
The classical signs.
Right. He defined 4 distinct signs of inflammation. There was rubor, which is redness, tumor, which is swelling, calor, meaning heat, and dolor, which is pain.
And then, what, a century later, someone added a fifth?
Yeah, the physician Galen came along and appended a 5th sign to that list, functio laesa, or loss of function.
Okay, I love this list because you can really think about Celsus and Galen's criteria like a building's fire alarm system going off.
Oh, that's a great way to look at it.
Right, so the calor is the literal physical heat radiating from the fire. The rubor, the redness, that's the flashing red emergency strobe lights on the ceiling.
Yeah, the visible warning.
Exactly. And the dolor, the pain, is the blaring siren that just makes it completely impossible to ignore the situation.
And then the loss of function, Galen's addition.
That happens when the security protocol triggers the fire doors to lock down. It makes the hallway completely unusable.
That is a perfect analogy. And taking that further, for over 1,000 years, doctors were basically just standing outside the building.
Just watching the lights flash.
Right. They could hear the sirens, see the lights, so they diagnosed encephalitis. But they completely lacked the tools to see the internal wiring triggering that alarm.
Until the microscope showed up.
Exactly. The barrier finally breaks in 1858 when Rudolf Virchow publishes his work on cellular pathology. He relocated the entire theory of disease away from those abstract ancient ideas, like balancing bodily humors, and pinned it directly on observable cells.
So inflammation becomes a mechanical process you can actually study.
Yes. And shortly after that, Julius Cohnheim literally watches the mechanism happen. He put animal tissue under a microscope and saw white blood cells physically squeezing through the walls of blood vessels.
Just migrating right out into the surrounding tissue.
Right. Which set the stage for this massive breakthrough in 1882 by a Russian zoologist named Elie Metchnikoff.
The starfish guy.
A starfish guy, yeah. He was studying starfish larvae under a microscope. And he takes a tiny rose thorn and just inserts it into the translucent body of this larva.
Oh, wow. So he can see right through it.
Exactly. And when he looked through the lens, he didn't just see cells passively floating around the injury. He watched the mobile cells actively migrate toward the thorn, surround the foreign debris, and just eat it.
That is incredible.
It was huge. He discovered phagocytosis. It's the process where white blood cells trap an invader in a vesicle and flood it with digestive enzymes.
Man.
He actually won a Nobel Prize in 1908 for mapping that out.
So Metchnikoff is the one who finally gets a visual on the microscopic firefighters arriving at the scene.
What's fascinating here is the chemical cascade that actually calls those firefighters to the scene.
Right. How do they know where to go?
Well, the moment tissue sustains damage, whether it's a splinter or bacteria, those injured cells instantly release chemical distress beacons, primarily cytokines and histamines.
And those histamines are like a chemical key, right?
Yeah, they bind to receptors on the cells lining your local blood vessels. It commands those cells to contract just slightly.
Which pulls them apart.
Exactly. It pulls the tight junctions apart, making the blood vessel highly permeable or leaky. And at the same time, the vessels widen to increase blood flow.
Which seamlessly explains all those ancient signs Celsus observed.
It really does.
Because the redness and the heat are just the physical result of that massive rush of extra blood, and the swelling is the fluid actually leaking out of those widened junctions.
Right into the surrounding tissue.
Yeah. And then the pain comes from that swelling physically compressing the local nerve endings, plus the irritation from the cytokines.
And the vital takeaway here is that acute inflammation is fundamentally protective.
It's a good thing.
It's a required mechanism. Without that vessel leakiness, the white blood cells couldn't escape the bloodstream to hunt pathogens. Acute itis is the necessary first stage of healing, not the enemy.
But having this one universal biological fire alarm creates a massive clinical problem, doesn't it?
Oh, absolutely.
Because while the alarm system is identical every time, the trigger that tripped the wire changes everything. I mean, it dictates whether you recover in a day or face decades of chronic pain.
Yeah, the text provides 3 wild examples of this. Let's look at appendicitis first. This is the acute bacterial model.
Right.
The mechanism usually starts with a physical obstruction. The narrow opening of the appendix gets blocked, frequently by a hardened piece of stool called a fecalith.
Which traps the bacteria inside.
Exactly. They start multiplying exponentially in a closed space.
And this is super common. The text cited a 1990 study showing a lifetime risk of about 8.6% for men and 6.7% for women.
Yeah, it happens a lot. And that rapid bacterial growth triggers the exact cytokine and histamine cascade we just talked about.
But because it's an enclosed tube, the swelling has nowhere to go.
Right. The pressure skyrockets, cuts off the blood flow, and the tissue begins to die from oxygen starvation.
Which is why this specific leiolitis is a surgical emergency. You have to do an appendectomy because drugs just can't work fast enough to stop it from rupturing.
Exactly. If it ruptures, it spills that bacterial load directly into the abdomen.
Okay, so that's the acute bacterial trigger. But moving to the chronic autoimmune model changes the timeline completely.
Completely. Take rheumatoid arthritis. There is no fecalith, no splinter, no bacteria at all.
The immune system just gets confused.
Yeah, it misidentifies the synovium, the delicate lining of the joints, as a foreign threat.
So the white blood cells rush in and release those chemicals, and over time, they literally erode the cartilage and bone.
And the scale of this is staggering. It affects up to 1% of the adult population, predominantly women.
And because there's no actual pathogen to clear out, the alarm just never turns off. It just continuously burns.
Which requires a totally different treatment. You can't just cut it out like an appendix. You have to use heavy systemic drugs that suppress the entire immune response.
Right. And then we have a third clinical presentation that kind of upends all the rules. Viral hepatitis, like hepatitis B and C.
The silent case.
Yeah, affecting hundreds of millions of people globally. It's this quiet, low-grade inflammation of the liver. But wait. If hepatitis doesn't have the classic pain or swelling, none of Celsus's classic signs, how can we even call it an otitis?
That is a great question, and it highlights the ultimate victory of modern microscopy over ancient observations.
Because of Virchow.
Exactly. Because of Virchow and his cellular pathology, today we defined otitis by the cellular infiltration at the microscopic level.
So even if the macro symptoms aren't screaming at you.
If a pathologist looks at a liver biopsy under a microscope and sees lymphocytes invading the tissue, the biological definition of inflammation is met, whether the patient feels pain or not.
That makes sense. But the reliance on that suffix has definitely led the medical field down some pretty destructive paths.
Oh, absolutely. When you have a catch-all category, doctors tend to force every mystery ailment into it.
Which brings us to the French physician François Broussais in the 1820s.
Oh boy, the leeches.
The leeches. He blamed almost all human disease on gastroenteritis, inflammation of the digestive tract.
Right. He took a single pathological description, slapped that suffix on it, and treated it by applying tens of millions of live leeches to patients' abdomens.
Just a massive category error. But sports medicine did something really similar in the 20th century with the tendinitis myth.
Yes. For most of the 20th century, if you had chronic tendon pain, like tennis elbow or Achilles pain, they diagnosed tendinitis.
Okay, let's unpack this. Because the doctors looked at the suffix, assumed there was an active inflammatory fire burning, and treated it with anti-inflammatories.
And aggressive corticosteroid injections, yeah.
But then in the late 90s, researchers like Karim Khan and Jill Cook actually looked at the tissue.
And what did they find? No inflammatory cells, no macrophages, no neutrophils,
Yeah.
just disorganized, degenerating collagen.
So diagnosing that wear and tear colitis is like having a mechanic replace your car's alarm system because the dashboard is buzzing, when the actual problem is a rusted axle.
I love that. You're treating the wrong mechanism entirely.
The anti-inflammatories were just earplugs for the mechanic. They muted the pain, but the tendon kept degenerating.
Which is why they had to rename it tendinopathy or tendinosis. That shifted the treatment away from rest and drugs and toward eccentric loading exercises to physically rebuild the tendon.
Proving that tendinitis names are really just working diagnoses, right?
Not eternal truths, exactly. A similar debate happened with chronic prostatitis, which they reclassified in 1995 as chronic pelvic pain syndrome, because, again, they couldn't find any measurable inflammation.
But it's not just doctors making these mistakes. Patients fall into the semantic trap all the time.
Oh, constantly. The most persistent misconception is equating endiditis directly with a bacterial infection.
Right, but endiditis just means inflammation. The infection is only one possible trigger.
Exactly. An allergy or an autoimmune disease can trigger it without a single bacterium present. But this confusion drives massive antibiotic overuse.
Like when people demand antibiotics for viral bronchitis.
Yes. The immune system triggers the itis to clear the viral debris. But patients assume the suffix means bacteria.
And the antibiotics do nothing to the virus, but they wreck your gut microbiome and breed superbugs.
It's a huge problem. And then you have the linguistic confusion, like cellulitis versus cellulitis.
Oh, yeah. They share a root word and literally nothing else.
Right. Cellulitis is a severe, rapidly spreading bacterial infection that absolutely requires antibiotics. Cellulitis is just harmless fat dimpling under the skin. Zero inflammation.
So what does this all mean for you, the listener? I mean, we have this whole family of suffixes. If I have neuralgia, I have pain, but not inflammation.
Right, because of the ILD.
And if I have a carcinoma, an oma, I have swelling, but it's a tumor mass, not an immune response.
Exactly. And a neurosis like arthrosis means an abnormal degenerative condition.
So think about the last time you assumed your itis required an antibiotic. The vocabulary really shapes our expectations.
It really does. And we also have suffixes for the surgeries that treat an analitis, like an appendectomy or an ostomy.
And we also have to talk about what happens when the inflammation escapes that local site.
Yes. When the local chemical distress beacons enter the systemic bloodstream, you get systemic inflammatory response syndrome, or SIRS.
Which, if driven by an infection, is sepsis.
Right. The blood vessels throughout the entire body dilate and become leaky all at once. Blood pressure drops catastrophically, starving your organs of oxygen.
So suppressing acute inflammation too much stops the healing, but letting it become dysregulated is fatal.
It's a massive misconception that all inflammation is bad and must be suppressed. Acute inflammation is healing. It's chronic, dysregulated inflammation that's the real danger.
Here's where it gets really interesting. This brings us to inflammaging.
Yes, this is incredibly relevant right now.
Chronic, low-grade inflammation is now recognized as a driving force behind the major killers. Heart disease, type 2 diabetes, neurodegeneration.
In atherosclerosis, it's not just passive cholesterol buildup. Macrophages infiltrate the arterial walls, die, and form a necrotic core. It's an active inflammatory disease.
And with Alzheimer's, it's linked to the chronic activation of the brain's immune cells. But this inflammation is completely silent.
Exactly. It's missing all 5 of Celsus's signs. No heat, no redness, no pain.
So it's tracked entirely via blood biomarkers, right? Like C-reactive protein or CRP.
Yes. If we connect this to the bigger picture, it's a profound irony. A suffix invented to describe obvious, painful red swelling is now the prime suspect in our most silent, invisible killers.
Our understanding is totally inverted over 2 millennia.
From macroscopic, visible signs to completely invisible molecular markers.
Which makes identifying the trigger so complex. The text notes how highly discussed myocarditis inflammation of the heart muscle became during the COVID-19 pandemic.
Right. The clinical data showed it was a consequence of the virus itself attacking the cells. But it was also seen as a rare, generally mild complication in young males following the mRNA vaccines.
Because the immune system was mounting a response to the spike protein antigen.
The exact same pieditis physiology, the cytokines, the cellular infiltration, but triggered by totally different things.
So, Aldatis names the process, the body's fire alarm, but never the cause.
Right. And as our microscopes get better, our terminology has to shift.
Which leaves us with a pretty heavy question.
Yeah, something to mull over.
Yeah.
If chronic silent inflammation is the main driver of so many modern diseases, and our diagnostic language is still rooted in ancient visible symptoms, do we need a completely new medical vocabulary for the 21st century?
We might just need a total semantic overhaul.
Ugh.
Thank you all for joining us on this deep dive. Look past the labels, question the mechanisms, and as always, stay curious.